So welcome back to our series. I'm grateful you're here. I hope you're all safe and possibly even enjoying some time outside. Before we introduce today's exciting session, just wanted to remind you that you can find our updated programming and a new newsletter on the website. Just Google Greenberg Bladder Cancer Institute. And I also wanted to remind you in detail about a couple of other things that are coming up. So next month, we will be welcoming Dr. Glenn Treisman to talk more in depth about identifying and managing distress and anxiety with a bladder cancer diagnosis. And I wanted to draw your attention to a new group of programs specifically tailored around the experiences of women with bladder cancer. These are being led by Drs. Armin Smith and Jeannie Hoffman-Sensis. And there's a program team of Pamela Getz, Samantha Rockler, and of course the great Stephanie Cooper Greenberg, who are launching this later this month. And I think what I'll do is I will go ahead and share my screen so that you can actually see the announcement describing the sessions that are coming up. So again, you can see on Tuesday, March 23rd, from 4 to 5:30, newly diagnosed with bladder cancer, questions I wish I'd known to ask. And then on Tuesday, June 8th, non-muscle invasive bladder cancer in women. So again, we're very excited about this new program, and thank you to all of you who helped put this together, and hope that all of you women will be able to help to attend this with us. Again, all of these are up on our website, and if we can help you directly, we're only an email away. Just email at us at bladdercancer, all one word, at jhmi.edu. So I'm grateful to all of you for joining us today for a conversation with Dr. Max Cates and Ms. Janice Carter. And the title of our session is When Bladder Removal is the Only Option. I'm so excited that our session today is really a conversation with Dr. Cates and a chance to hear directly from Ms. Carter. Just to remind you, Dr. Max Cates is a Brady-trained urologist, did his residency here, who attended Mount Sinai Medical School in New York. And while there, he did a Doris Duke Clinical Research Fellowship at Columbia University, where he established some tight ties with the group there that are part of a major research program of ours. Max is a leader here in the Greenberg Institute, where his practice focuses on patients with bladder cancer. He has received recognition nationally from the American Urological Association and also from the Bladder Cancer Advocacy Network, among others. However, it's really the feedback from his patients and their families and his strong sense of communication that has inspired this conversation today. So I'll let Dr. Cates make a more meaningful introduction of Ms. Carter and encourage you to use the chat function to ask questions. And we'll come back toward the second half for a more specific question and answer. So without further ado, Dr. Cates, take it away.
Okay, can we see if I can start my video? Perfect. Okay, wonderful. Sorry, I'm in a patient room. I just finished some procedures today, so that's why you see me still in my scrubs. I'm looking at the group of attendees, and I recognize many of the names, many friends. As I turn off my phone, I apologize. That's rule number 1 of Zoom. Should stop soon. Give me 1 second. See how to get rid of this. Okay, good. So anyway, when I see a lot of friends here, a lot of patients, and when I thought of the title of this talk, or when the title was given to me, I honestly have some issues with it. when bladder removal is the only option. But I did not tell them to change it because I thought it actually was a good discussion point in and of itself. Because, you know, my philosophy and our philosophy, you know, here is that, and my patients know this, is that there's never only one option. There are better options, and you know, I wouldn't hesitate to tell people it's the best option, but there's not one only option. I wouldn't ever use the word only, because the patient is really at the center of this major decision, and it's a balance of priorities, and every patient's priorities are very different, and we can talk a little bit about that at the discussion point. I purposely did not want to make slides for this talk because I really want to know, you know, what people are actually interested in discussing, and we can get into specifics, as specific or as general as people want. Once we get into the chat, you know, I'll ask that if it's exactly your exact scenario as the patient, and you don't think it's maybe the best thing for the whole group, then maybe we won't talk about it. But otherwise, you know, it's free game, free for all. Okay. And I really want it to be like that. But first, I thought the most meaningful way we could sort of open up this discussion about when do you decide to have your bladder removed, and how do you go about making that decision, and what are the implications in that, and what is the quality of life experience, rather than have me tell you what it's like. Wouldn't it be better to have you know, a patient tell from their own experience sort of what that journey is like, and how it's been in their experience? So I want to, you know, in that vein, introduce Janice Carter. You know, Janice is, Ms. Carter is just an absolute, just genuinely kind person that I'm very privileged to have gotten to know as a patient. She's also in healthcare. So she does have a good understanding, although maybe her perspective, you know, has changed as being on the other side of being the patient. You know, but having said that, you know, we're very lucky to hear her today, you know, about her experience and what it's like to be making these decisions, and then what it's like during the journey and afterwards. So without further ado, Janice, thank you so much for being willing to share your story to us, and let's kind of start from there, and thank you. So let's hear from you.
Well, hi there, everyone, and thank you so much for having me, Dr. Cates. My bladder cancer journey actually started in May of 2019, and I was about 1 month before my 55th birthday. I say technically because prior to that, I had many years of issues with my bladder. I suffered from interstitial cystitis or painful bladder syndrome. So I had lots of pain. I dealt with urinary urgency, frequency, and it actually wasn't uncommon for me to often see blood in my urine. Somewhere in the early part of May of 2019, something changed. Something was a little different. My pain levels changed. The frequency with which I actually could see blood in my urine changed. And it made me go to my primary care doctor, who referred me to a urologist. And before I could make it to my urology appointment, I wound up in the emergency room with terrible pain in my flank, and wound up that I had some hydronephrosis, but I was also at that time diagnosed with bladder cancer. And shortly after that was when I met Dr. Cates. I had T2 high-grade bladder cancer, And, I met with him to figure out what the plan would be. And he's absolutely right. He never told me, Janice, this is what you have to do. But he gave me all the options. I talked things over. And once I made the decision, it was full speed ahead from there. I was very comfortable with the decision, the information he had given me, the research I did on my own, and decided that bladder removal would be the best thing for me to do at the time. And so I moved ahead, and I did do neoadjuvant chemotherapy for 3 months. And by November of 2019, I had my radical cystectomy. And I had decided the diversion I would get would be an ileal conduit. And I underwent the surgery at that time. So I can't say it was an easy journey, but right now, here today, I'm so happy that I've come as far as I have. I've gone through it. I worked to get back to where I was prior to having the surgery, and I'm back to doing all of my everyday things, working. I can't say I was ever an athletic person, but definitely a weekend warrior. So, I hang out with family as much as we could during this pandemic. I'm stuck close to home, but my husband and I are working toward getting back that quality of life and doing the things that we like to do, and looking forward to when things kind of open up and get going again with this pandemic. So I'm not sure if folks have specific questions for me related to my experience, related to the surgery or my decision-making process, but I would be happy to address any of those things as best that I can.
So first of all, thank you for that. I think that was, I think telling your story in front of, in a large group of people is not easy. And, and so thank you. I'll get it started while people, if they want to use the chat function, they can use the chat function. And by the way, if you have questions that are not specific to Ms. Carter, that's fine too, and we'll answer them as well. But specific to you, I want to talk to you a little bit about the decision you made about the urinary diversion, if you don't mind sharing with us that, because I think for a lot of patients, that is a difficult decision. And so I'd love to know just your thought process and how you went about thinking about it.
Well, I have to say for me, it may be very different than it is from other people. And you and I had kind of talked about this. I think early in this process, I did lots of research, and I came across folks who were very interested in sparing their bladder. That totally was not me. As strange as it sounds, that just wasn't me, because I had had so much pain, so much difficulty. At that point, I was using the bathroom every hour on the hour, day and night, based on the problems I had even prior to my bladder cancer diagnosis. And we talked about the surgery and what it would entail, what the recovery would be. And I knew that was the thing for me. I just knew that my quality of life would actually be better after that type of surgery. So it was a matter of figuring out then the diversion. The neobladder really was not the best option for me because I had the interstitial cystitis and so many problems prior. So then we narrowed it down to the ileoconduit or the Indiana pouch. And frankly, I'm no spring chicken. I'm not a gambler. I wanted something that's pretty no muss, no fuss. You can probably tell by how wild my hair is that I'm a low maintenance kind of gal. So I think the ileoconduit was just, after talking to you, I knew it was the thing that would cause me the least amount of problems. I certainly had to put the work in the beginning, but in the long run, it was the most straightforward, problem-free solution for me.
Okay, thank you for that. Yeah, we're starting to get some questions, so this is very good. So we have a question. Please first let me express my gratitude for your candor and willingness to share. Was your cancer CIS or papillary? And I can sort of help address that part of it. And did you consider trimodal therapy, which would be chemotherapy and radiation, or other clinical trials? I think suggesting clinical trials that would spare your bladder. So I will just kind of jump in a little bit on the first part of the question, which is once bladder cancer has started to invade the lining of the bladder such that it invades the muscle, it is by definition sort of an invasive cancer. And so while we think of non-muscle invasive disease maybe as CIS or papillary, once it's actually invasive into the muscle of the bladder, that distinction stops to have as much relevance. But, you know, the one area it may have relevance, and this goes into the idea of trimodal therapy, is certain patients are, I would say, better candidates to receive chemotherapy and radiation, or what's called trimodal therapy, which is a way to preserve bladders. All right. And I will just tell you, you know, in briefly how we think about that with patients, right? So I always will bring up chemotherapy and radiation as an option. But as I said, I will be very upfront in where I think one option may be better. In Ms. Carter's specific case, in somebody who is going to the restroom every hour, you know, having radiation to the bladder is a little bit of a recipe for disaster, to be quite honest. And I think we talked about this, but that is not somebody whose quality of life will be improved from their bladder cancer treatment. So it's a very nuanced discussion. Somebody who has CIS throughout the bladder, that's somebody who typically is not going to respond super well to radiation, although there are some camps that would dispute that. But by and large, CIS or carcinoma in situ, those flat cancers where the whole bladder is sort of diseased, not going to usually respond very well to radiation. And then there are some other nuances. But, you know, so this is where sort of the art and the science collide. And at the center of that collision is the patient and what are their priorities. So I think, you know, you heard, you know, Ms. Carter say, I'm a low maintenance gal. I was going to the bathroom every hour and I want a solution where it's going to be, you know, life, you know, affirming and preserving for my cancer treatment. Hopefully improve my quality of life, because their quality of life was not great at that point, and relatively low maintenance. That is not everybody's top 3 priorities, although, you know, that could be many people's. So I think that's kind of the take home message in that. And Ms. Carter, did you want to add something to that?
You summed it up perfectly. Yeah, you summed it up perfectly.
Okay, let's keep going with some of these questions. This is really great for those of you asking questions. It's very helpful. I want to keep encouraging that. Two questions for you, Janice, about your sort of recovery. Any pearls, or can you say something about what has been helpful in your recovery from surgery and from chemo? And before you talk, you want to also tell people sort of what you do professionally along those lines?
Sure. So Dr. Kate said that I am a healthcare professional. I actually work in occupational therapy. And at that time, I was in the hospital. I did not sit behind a desk. I was very active. I moved around quite a bit. I was required to do heavy lifting for my job. I was by no means an active athletic person. I considered myself to be more the weekend warrior type, where my mind thought I could do things that my body really couldn't, but I give it a shot every now and then anyway. So that was my starting point. Chemotherapy was not easy for me. It was somewhat difficult. I was anemic most of the time. So the anemia combined with the chemotherapy really did take a lot out of me. I still tried to move around somewhat. I was not working at that time because Dr. Cates and I thought that best given the role I had at my job. So I went through chemotherapy. Once I was finished with the chemo, I tried to build my body back up as much as I could to get ready for the surgery. However, that also was difficult, but I did the best I could. And the recovery process also, the best thing I can say is it takes time and you really need to work at it. When I was in the hospital recovering from the surgery, my anemia continued. I had issues with my blood pressure being low. So normally you're able to get out of bed and move around much sooner than I was able to following the surgery. So I think I spent at least a day or two in bed, whereas ideally you would be up and walking and moving around. But then once I was able to get up and out of bed and keep my blood pressure stable and that kind of thing, you start out, just walking in the hallways of the hospital at that time. And the more you move around, the better. I can say as far as tips in my recovery, just move as much as possible. Walking is great. I started out, the big highlight of my day was walking out to my mailbox. And now I'm up to, a few miles a day, 5 or 6 days a week. So it's just really a process. Drinking lots of water. Initially, it really is hard to get the food in and the water in. I didn't have much of an appetite. And it's like, okay, if I eat, I won't have room in my stomach to drink. If I drink, I won't be hungry. So you just work through it and find that balance and try to do the best you can for a while. But, after, some time, things level out and you get back to more of that sense of normalcy. I think after about a month or so, I was asking Dr. Cates when I can go back to work. And he was like, well, not yet. It takes time. Don't worry. It takes time. You'll get back. We'll get you back. It just takes time. So you just have to really have some patience in your recovery and try to do the best for yourself and your healing. your body really does need that time to heal and recover.
Fantastic. The question and answer board is continuing to ask some really good questions. Just along those lines, when would you say you felt human again? I'm not sure what that exactly means, but I think patients may get that.
I'm still working on that. No, just kidding. I feel like it human. I feel like it took maybe a couple months. I really do. I feel like it took a couple months, and things leveled off a little bit. I was in a routine, but initially, the smallest thing was, I would just be really wiped out. So it took quite some time. I think I went back to work on a modified schedule after 3 months, which my employers were amazing and kind of let me split and do some things where I was moving around a bit, but then also some sedentary computer desk work, which helped a lot. I could take that time to ramp up to get back into my routine at work. But yeah, I would say a few months for sure.
All right, I'm going to keep pushing the button on you because a lot of these questions are geared towards you.
Okay.
Can you talk about the mental adjustment to the ileal conduit? I'm not as far out from surgery as you. Congrats on where you are today.
So there definitely was a bit of adjustment for sure. But, early on, I kind of weighed the options. I got the information, and I don't know, somewhere I just came to the decision. I talked things over with my husband, and, he was good with it. And once I had made the decision, I knew it was a decision for me, and there was no looking back. It was just full speed ahead. And I almost took it is what it is sort of attitude, because I knew it was the thing to do, and I knew I would get through it and do what I needed to do to get my health back.
So along these lines, there's 2 questions. One of them is in the chat. I would just ask people, because I'm missing questions in the chat, use the Q&A for your questions. But they're kind of along the same lines. First of all, Ms. Carter, thank you for speaking out. It's brave. I'm up to walking a few miles too, and I can sleep at night. So then there's a question, 2 questions about conduits. The first is about issues with skin issues. I don't know if you want to speak to that. I can also speak to that. And the other is on hernia prevention and how to deal with hernias, which I can take. But do you have any thoughts on those?
I will say that I have been very, very fortunate relative to skin issues. I have had none. So typically I'll change my pouch at this point twice a week, every 3 or 4 days. And I really have to remind myself, because there are times when I can go longer. But I know that day 3 or 4 is better for my skin. Sometimes, you remove the pouch and there may feel a bit of irritation or something if I go beyond that 4th day. As far as leakage from the pouch, I've had very few issues with that, once I got through those first few early months, and got things figured out with which appliance I wanted to use and so forth. I don't, I have to remind myself if I'm going far from the house to bring extra supplies just in case, because I just usually don't have problems with that.
And I'll speak to hernias because that's a very thoughtful question and something that I think about a lot. So, no, as many of my patients have heard me say, no good deed goes unpunished. So there's always going to be issues with every decision that is made. And even though the ileal conduit, some people describe it as sort of more straightforward or hassle-free than some of the other diversions, which may or may not be true. It depends on who you are as the patient. One of the common things that can happen with the ileal conduit is a hernia, basically a pooching of either the conduit itself or some of the abdominal contents, around into the hole where the conduit sits. And, it's very interesting. A group at USC, based on some literature in Europe, is currently doing a trial to see, well, what if we placed mesh in everyone under the conduit? I don't know if that's the strategy. That's a randomized trial that's being proposed. I worry that, as I said, no good deed goes unpunished. So placing mesh may have some issues in people. So I don't think we've sorted that out yet. As a field, there are certain technical things that I do and I teach to those who train with me. But inevitably, many patients, depending on what you read, 20 to 30% will have hernias. Now, the vast majority of those can be managed with hernia belts. And hernia belts in the last, I would say, 5 years, and I am not a stoma nurse. Those of you who know Rhonda know that she's the guru. I am not, but I have learned a lot from her and a lot of the other stoma nurses. And what I'll tell you is hernia belts and the technology around sort of hernia belts have gotten much better. So there's a lot of ways to manage a hernia that's not going back to the operating room. That's actually very rare. I can count on less than one hand the amount of times I've seen that. Okay, it does happen sometimes, but it's very rare. What's more common is being able to manage, a hernia with a belt or various appliances. Once again, the technology has gotten a lot better. So I'll leave it at that. And we'll keep going. One question that I'll also answer is, what if you've had your kidney removed prior to bladder removal? That's actually it's not uncommon, especially at a place like Johns Hopkins, where we tend to get referred in a lot of what are thought as sort of more difficult surgical cases. And the reason it's not uncommon in our practice is that a lot of urothelial cancer that's in the kidneys, many of those patients, even after kidney is removed, will have recurrences in their bladder, okay? About 50%, depending on the literature you read. So it's quite common to need to either remove a bladder or do trimodal therapy in the setting of having your kidney removed. The ways in which the subtleties might be that might complicate things is if after the kidney is removed, the kidney function takes a little bit of a hit. Sometimes it does, sometimes it doesn't. Sometimes patients that would preclude a patient from being able to get certain types of chemotherapy, either with their trimodal therapy, with their radiation, or with their surgery. So that's a lot of information there, but that's sort of the subtleties and sort of how you think about, removing the bladder in the setting of having had a kidney already removed. Okay, we answered that question. So there's along the lines of, so I'm not going to say specifics to each person's case, but I want to answer and address the underlying question, especially because I just talked about this. So there's a question about, being a candidate for trimodal therapy, not being a candidate for trimodal therapy because of kidney malfunction. I would think of that as sort of chronic kidney disease. And that is not a contraindication necessarily for a kidney malfunction. Now, if the kidney is swollen, that's called hydronephrosis, that may be a contraindication to trimodal therapy, because that might suggest that the tumor is actually invading deeper into the muscle layers such that it's obstructing the kidney. And historically, according to the literature that we have on trimodal therapy, those would not be ideal candidates, for chemotherapy and radiation. The ones that have tumors that are causing their urine to be backed up into their kidneys and cause kidney swelling. So these are when I talk about the subtleties in talking about bladder removal versus trimodal therapy versus anything else. This is some of the stuff that comes into play. Is actually there's quite a few details, and the point is not to say to a patient, you're not a candidate for this. It's basically to say to a patient, these are the options, but given what we know about your disease, the options are equivalent, or this may be a better option. And I have no qualms telling somebody this may be a better option if I think it may be a better option. A lot of times there might not be a better option. So this is some of the subtleties, sort of how you take somebody through that. There's a specific question about, and this speaks to, I'm going to just give up, say that we probably are due to have a ileal conduit stoma patient group like chat. And we used to do that more. And I think in COVID, we've gotten away from that, but we're definitely due for one of these because we have a question about how can you accommodate high volume output from a conduit. And at night, people do a lot of different things, but I'm going to say, Janice, do you have any response to that? Any strategies?
I feel like I haven't really had an issue with that. And, I do try to keep myself hydrated. A normal day for me is 64 ounces of water minimum. So I'm 64 or above, or I'm having a bad day. Nighttime, I do connect to a night drainage bag. And this has been the first time I slept through the night in 20 years. So I know when I leave the house, I do empty the pouch before I leave, depending on how long I'm going to be out, especially in this COVID environment. I'm not using public restrooms. So I will empty, but I can go several hours without the need to empty.
So I want to pause there because I think what you just said is really important. You had not slept through the night in 20 years.
No, yeah.
And I can't tell you how common that is among bladder cancer patients, men or women. Will tell me, I want to keep my bladder. I want to keep my bladder. I want to keep my bladder. And sometimes, they're absolutely right. They should keep their bladder. But sometimes it's that there's a fear of what it means to not have a bladder. And if you start asking them, well, tell me about your life with your bladder, you learn that they're going, they're waking up 2, 3, 4 times a night. They're going to the restroom every hour and a half, maybe not as severe as maybe the symptoms you had, but they've learned to be accustomed with sleep patterns that are not normal. So that's not to say that everybody should have their bladder removed, but I think that there also is a conversation that happens about what is your current quality of life with your bladder. That is really important when you have these conversations. I'm going to keep going with these questions. These are, by the way, these are fantastic questions. Do you use a leg bag at all with along these lines with in any way?
I have not. I have them. I'm familiar with them, but I really haven't had need to use it.
Yeah.
Not so far. I think about, if I get back to traveling, something like that, I may find that it comes in handy to try, but so far I haven't had the need.
Yeah, I kind of cut off the question about the high volume output after you went. I'll go back to that just for 1 second and say that basically the wrong answer is to decrease volume of intake, fluid intake. That's the wrong answer. So in my opinion, meaning hydration is really important. And why do I say that? Because the number one, and I tell every patient this, the number 1 and 2 reasons why patients get readmitted to the hospital are dehydration and urinary tract infections. And urinary tract infections typically are related to dehydration. So that is probably not the right answer. But in terms of other strategies, I honestly would suggest that we do a panel, and I know that a lot of the leadership involved in this is on the Zoom right now. I think we're due for sort of a patient group on sort of stoma care and issues like this, because I honestly think the right answer to that is having 20 patients come together and 4 or 5 of them will have high output, and we'll figure out what works much better than you know, me postulating something. So I think that's what we should do there. Okay. There's a question here about adjuvant treatment, standard of care. And that's a really good question. So let's talk about it. So when do you need treatment after a cystectomy? So neoadjuvant is what Ms. Carter had. That's treatment. It's a generic term. She had neoadjuvant chemotherapy, but neoadjuvant means treatment before surgery, leading up to surgery. Adjuvant means treatment after surgery. Usually, you know, within a couple weeks to a month or 2 after surgery. It's very clear, according to our guidelines, when we would do that. There are scenarios in which somebody does not get chemotherapy before surgery. They could have too much symptoms, too much bleeding or too much pain, or they could have non-muscle invasive bladder cancer. And then we do surgery and we find that they had muscle invasive bladder cancer, and it may or may not be involving the lymph nodes, okay? And in that situation where they did not have chemotherapy before surgery, we would recommend chemotherapy after surgery. We also have open at Hopkins a very exciting clinical trial that's being led on a national effort by Dr. Andrea Apollo at the NIH. And what they're looking at is whether in patients who, even if they've had chemo before surgery, or they can't get, or they're not candidates for chemo after surgery, well, should those patients get immunotherapy? Should they get immune checkpoint inhibitors if they still have muscle invasive disease at the time of their bladder removal, if it looks like the chemotherapy really didn't do enough? And so that is a randomized trial that is randomizing half of the patients to receive immune checkpoint inhibitors and the other half to do typically what we would do right now, which is get CT scans on a frequent basis to see, well, would it help to give those patients who are at slightly higher risk of cancer recurrence, would it help to give them immune checkpoint inhibitors? So we have that trial open at Hopkins right now. So that's just a good excuse to talk about that. I think that along those lines, you know, Ms. Carter, can you just talk about, and this is something that can be difficult a little bit for patients to talk about, but just talking about, you know, the future and sort of how you approach, you know, there's a lot of, you know, CT scans or, you know, how you approach the surveillance now that is going on, you know, mentally and emotional.
Yeah, I have to say that, you know, I've been monitored through the first year. Every 3 months, I go get the CT scan and the blood work and such. And it still is anxiety provoking. You know, we've talked, I've talked to Dr. Hahn, my oncologist, and you know, he tells me everything is great. I haven't had any problems, knock on wood. But you know, it's difficult to get around that feeling where you're waiting for the other shoe to drop. Like, why are things going so smooth so far? But having said that, it's just a matter of doing what I need to do and making sure that I keep those appointments. I get the CT scan when it's due. This second year, I go every 4 months instead of every 3 months. So, I get myself psyched up to do it. I have my appointment, find out the results. And so far afterwards, I celebrate.
How do you celebrate?
Oh, it depends. Usually my husband and I'll do a little toast or something, or go out and have lunch, or during this pandemic, pick up some good to go takeout, support a local business or something. And
Yeah, and I see, Dr. Han is actually, he's logged into this, and that's just an excuse to just talk about how, we're talking today about bladder removal, but, one of the great things about being able to be, in my job is we have a team. And so, in this case, it's Dr. Han and I. If we're doing trimodal therapy, there'll be a radiation oncologist involved. There's just a lot of people. Rhonda, intimately involved if there are stoma issues. So far, Ms. Carter sounds like she's not had many, so that's great. But the point is that the team is essential even during that sort of surgical time period. It's arguably even more important. Okay, let's keep going. Couple more questions and keep asking them. We have a little bit of time left. Somebody's asking about exercise to prevent hernias. Yeah, I mean, hernias are a tricky thing, right? Because we definitely want the abdominal wall to be strong, but one of the ways people get hernias is sometimes by sudden strenuous movement. So, I think once again, in my opinion, we probably should do a better job at identifying risk factors in people for hernia. And in those people, think about prophylactically placing mesh in those high-risk people where the benefits might outweigh the risks. But I think we have a little bit more to learn about that. And once again, I think that the vast majority of them can be managed conservatively with conservative measures. And then we have a comment of a patient. Sounds like he has a lot of success with a leg bag. So yeah, once again, speaks to that, every patient's going to have something that works for them. And I think it's really important, to continue to be on sort of, be involved in patient group. I always want people to be involved in Beacon and in the GBCI groups because you learn a lot that way. We have a good question. Can you talk to us about how having a conduit has affected your dressing style and the kinds of clothes you wear and sort of how you approach fashion, however?
Sure. I will say that I spent at least 2 months in sweats. My surgery was in November. And so, those first couple months, I didn't want anything tight. I wanted loose fitting, warm, comfortable clothing. After that, I went back to most everything that I wore before. There's really no change. I've never been one to wear anything super tight or anything like that. I do wear fitted things, yoga pants and leggings and that kind of stuff. And I just look at where the cutoff of my top is. Usually I have a tendency to wear shirts on the outside, but that doesn't mean they have to be big and loose and baggy. It's just not fitted in the place that's over where my pouch is. So maybe a little experimentation, underwear and that kind of things. I kind of looked at, high waist versus a lower cut. And I'm just more comfortable with something that comes up a little bit higher. But other than that, I wear basically the same type of clothing.
That's great. One of I believe I'm assuming here it's a male patient is suggesting suspenders, which actually a lot of my male patients wear suspenders actually. So that's a good suggestion. So there's a question I think I might be actually, you might have some thoughts here too. What can you do to prepare yourself physically to create the best outcome should a bladder removal be necessary? So, that's a really good question. And certainly, physical fitness is really important, meaning, not meaning you're a marathon runner, but meaning, you can walk a couple flights of stairs without many issues. That's a good trigger for me to understand that. Lifting weights and training, which this particular question is asking about. Yes, that is, that's always helpful. Losing weight, always helpful, never hurts. And I'll say that we have, and something that is being developed is, and that we're developing is in patients who may be a little bit high risk. So maybe, a little more frail, have some more issues. We are getting them involved in a prehab program. That stands for prehabilitation program, in which we may be sending them to physical therapy before surgery. Okay, we may be doing things like that, and that's really important as well. There's a specific question about robotic versus open radical cystectomy. Those of you who are my patients or who know me know I do both. I can't even remember which one I did on Miss Carter. Miss Carter, did I do yours?
Open.
I did yours open. Okay.
Yes.
So I did Miss Carter's open, there occasionally is a reason, and usually a lot of times there is a reason why I might want to do it one way or the other. My practice is roughly 50-50, but in terms of recovery, we do a what's called an ERAS program, so an early enhanced recovery after surgery program. And in that program, the average length of stay is the same, robot and open. It's really the bowel resection, taking a piece of intestine. That's what keeps patients in the hospital for 4 or 5 days or sometimes longer. So it's not really whether they had it open or robot. So there's a number of factors that may come into play with that question. Good question. Okay, the next question is yours, and then the next question is mine, and then we'll see if we have any more time after that, because we have just a couple more minutes. So have you tried ostomy wrap or stealth belt to support the pouch, or any other specific products you find helpful?
So I have not tried the stealth belt. I have gotten a couple of the belts from Ostomy Secrets that are fantastic depending on the type of outfit that I'm wearing that day or the activity that I'm doing. Sometimes if I'm out and about, I don't know, biking or something like that, and I think I'm going to be out for a period of time where the pouch might get a little full, I like to have that extra support. So wearing one of those belts can kind of help support my appliance if I think I'm doing something that I want a little more security. So yeah, I do have a selection of a few of those that I have used.
So we have a question about nerve sparing surgery. And yeah, I will tell you that that it is something I'll talk to my patients about. So the nerves that surround the prostate, really, and the vagina control sexual function. And I do preserve those nerves. Even when you preserve the nerves, there's still a risk of sexual dysfunction in certain ways, in men, specifically erectile dysfunction. And what I tell patients is we can, what I tell male patients is we can get that back, whether it be pills, injections, or sometimes another surgery. So if that's important to you, we can get it back. And that's part of the conversation. Really interesting in women, there's a lot of research. We just opened up a patient questionnaire trial last month or the month before, trying to understand, women's sexual function after cystectomy, because it's not something that's discussed very much, to be honest, in the literature. We've actually put out some of the most research on it, but it's something that we now have a trial open that's patient-centered and that we're actively investigating more. Can you discuss SBO prevention? That's small bowel obstruction prevention. Yeah, so that speaks to our ERAS program. We have a very tight program to try to prevent bowel-related complications after surgery. And one of the revolutions that's happened 3 or 4 years ago is a new drug called a mu receptor antagonist. And what it does is it promotes bowel motility after surgery, and it decreases length of stay from this surgery by a full day, which doesn't sound like a lot, but it's a lot when you're talking about 10,000 patients on average are getting out of the hospital a day earlier. That basically means it's reducing the complications that would make somebody stay in the hospital longer. So we're doing that, and a number of other things. We have a question about, are there alternatives that do not involve an outside retention pouch? This is I feel like this is like the end of the session, and so it's like the rapid fire at the end of a game show. That's what we're doing right now. Yes, there is an Indiana pouch, which is a type of continent cutaneous diversion where you catheterize a pouch. Pros and cons to that. And there is a neobladder where we make a sphere and we reattach it to the urethra. Pros and cons to that. There is no way to reformulate the bladder that you're born with. You may or may not want it reformulated, but there's no current way to reformulate that. So there are pros and cons to each approach. And this is very much of what we do when we sit patients down and talk to them about bladder removal. DVT prophylaxis, yes, we do it. And now we're actually sending patients home on 30 days of an injection to prevent DVTs. Ms. Carter, did we do that with you?
No.
Okay, so we're doing that to prevent. So we're constantly tweaking things to try to prevent these complications that can happen. And the last question is for Ms. Carter, and then we're going to stop. And it's really really addressing your experience with chemo, which I think you touched on a little bit, but this seems to be what the patient is more scared about than the actual surgery.
Yeah, so chemo was a bit challenging for me. Definitely the things you hear about having low energy and that kind of thing, they held true. I did not have a whole lot of difficulty with nausea and that kind of thing because they pre-medicate you before every session. So that worked out fine, even though there were issues with appetite. I can say my biggest complication related to chemo was that I was anemic for much of the time, which at a couple different points I had to be transfused because my numbers got so low. And then I developed folliculitis in my scalp where my whole head felt like it was burning, and that was taken care of quickly with some medication. The type of chemo I had, they said there was a 50-50 chance I'd lose my hair, and I did have my hair start to fall out during my second round. But it grew back. But yeah, it just really zaps your energy level more than anything for me.
You know, what I tell people is, you know, we wouldn't do it if we didn't think that, you know, there was a real genuine survival advantage from doing it. And that's what our studies show. And so, you know, and we can talk about specific scenarios with patients, you know, as they come, but yeah, but I think we're going to stop now. I don't know if David wants to get back on, but I just once again really want to thank you, Janice, for your being so brave and basically being a lot of these panel type things are like, you know, usually we have like 2 or 3 patients. I knew you could handle an hour on your own.
Oh.
So I said, no, it's just going to be the 2 of us, you know, but I just want to tell you, you know, how great, you know, and how brave this was. So thank you.
Yeah, I'd like to thank you too, Janice. Fantastic session, everyone.
Thank you so much. Thank you both for having me.
We'll see you all next time. Stay well, and we'll see you soon.
All right.
Bye.